course, because the time is very limited, so we should save our time. So I think we can start. Almost all the Chinese colleagues come in, and I guess that also for your side, our colleagues from your side are almost join us already. Yeah. Here. So very glad to have these opportunities to have this joint conference for the clinical management of the COVID-19 with our colleagues from United States. So the situation in the both country is now is different, but I think that situation in the United States is get worse, but I hope will be get better soon. So today we will have this chance to share our experience and also have opportunity to answer some questions raised from your sides. So firstly, I would like to introduce colleagues from my side, the Professor Wang Kai, the Vice Director of the Hospital, Union Hospital of Wuhan, and also he is a cardiologist. Hello, Wang Kai.
Hi, I'm here.
And also Professor Xin Zheng, the Director of the Department of Infectious Disease, and also the Professor ZHAO Lei, the Deputy Director of the Department of Infectious Disease, and also Professor Baoju Wang, Associate Professor of Department of Infectious Disease, and the Jia Liu, also Associate Professor, Department of Infectious Disease, and Jun Wu also come from the same department, Associate Professor, and our guests are Professor Qi Hong is a professor from the Department of Intensive Care Medicine, and also the Dr. Wang Xiaorong, the attending physician of the Department of Respiratory Disease. The last colleagues is Dr. Fan Yunzhou, the staff from the Department of Nosocomial Infection. So welcome all of you to join us, and thank you very much. Now I'll give the hands to Marcus.
So we want to thank you very much for your speaking with us about your experience. I'm sorry if you can't hear me well. I'll speak as loud as I can. Also want to thank Professor Kai and also Professor Zheng for the opportunity to speak with you. I was in, as you know, I was in Wuhan in November. I had the pleasure of meeting with all of you and seeing the wonderful work that you were doing there in our collaboration. And we very much want to hear about your experience under the great efforts of the Chinese people, especially the doctors and nurses. You have made really a historic control of the epidemic in Wuhan. And we know that we can learn a great deal from you, and we're very excited to hear from you. On our end, we have combination of our leadership from cardiology, from internal medicine, infectious disease, and critical care. So we're very interested in hearing your experience. Thank you very much.
Okay, thank you. And now I would like to invite Professor Huang Kai to give some words as a start of our conference. Please.
Okay, thank you very much. Dear Professor Marcus Devers, Professor Canis, and all experts from the Wayne State University and the Henry Ford Health System, good morning. Today, we hold this online session on prevention and treatment of COVID-19 between Wayne State University and the Union Hospital of Huazhong University of Science and Technology in this very special period. As we all know, Wuhan was at the epicenter of the Chinese outbreak, and our hospital has undertaken a series of tests, including nucleic acid testing, of the virus, designated hospital to treat the COVID-19 patients and very severe patients, and treatment of for all of them. And thus our experience has been enriched through the compact against the virus. Now the situation in Wuhan is increasingly going well, and as all we know from the television, Wuhan the situation get better. And but we really worry about the situation in United States and the other the countries all around the world. WANG State University is a new friend of our hospital, and in last November, Professor Michael Zivas and Professor Mong visit our hospital and communicated with our, the colleagues in the Department of Infectious Diseases with the support from the Clinical Medical College. Now that the COVID-19 was declared as a pandemic, and we will share our, experience and try our best to help you address the, the challenge, do our best, and anyway and anytime. And in each crisis, there are so many challenges, but also the chance. We will work together. We will work with you to strengthen the communication and collaboration and jointly address the challenges. Okay, and that's what I want to say. Thanks.
Okay, thank you very much for your kind words. So I think we can start. As we discussed before with Professor Marcus, this conference will be separated to 3 parts. Firstly, my colleague, Professor Xin, will briefly give an introduction about the clinical management experience from our hospital. And the second part will be the answering questions raised from United States parts, your parts, and the total of 23 questions will be answering from different colleagues from my hospital, one by one. And the last part will be the free discussion. If you have any questions, you can just raise your hand at any time. Welcome. So it's okay for you, Marcus?
Yes, that's perfect. Thank you.
Okay, so please, Professor Xin, please start in your brief introductions. Welcome.
Good morning, our American colleagues, and good afternoon, our Chinese colleagues. Okay, it's really my pleasure to have here to share this our clinical experience. I still remember last November, yeah, we met with Marcos and we have a very nice talking. We're talking about that. We're working on emerging infectious disease. We're also talking about that intensive care. And we really don't know it's coming so fast, the emerging infectious disease. So for our hospital, we started to fight with this disease in the beginning of this year. I think we have very, very hard time right now, even though it's better, but okay, then next. Then next, yeah. But every day when I saw these numbers, it let me think about that, the responsibility of being a physician. So there's so many people pass away, and there's so many increasing SARS-CoV-2 infection people. I think we really want to do something for helping the peoples. Actually, we did some work with Germany, so we really like to share something with you too. Next. Okay, so this is the outline of my brief talk. And part 1, I think, is very important, how to identify the severe patients at the favor clinical and isolation ward. And the second part is the principal treatment of COVID-19. Okay, next. Yeah, I think these slides just show you the real world situation at the favor clinical, especially in Wuhan. We have so many patients, and we are shortage of medical staff, and even though for the favor clinical space is very limited, so we have to expand the, the favor clinical more and more. But actually, for all these patients, some of them are non-COVID-19, and some of them maybe just the mild patients, but some of them may be really severe and critically ill patients. But of course, some of them, they are potential severe patients. So, okay, next one. Yeah, so our duty is the first, we have to exclude non-COVID-19 patients. So how can we do that? So when the patients come to our favor clinical, yeah, we ask the patients to finish the following test. First is a routine blood test, and then CRP and the chest X-ray or chest CT scan. But in Wuhan, we prefer to do the chest CT scan because for chest X-ray, somehow you can not see the lesion very clearly. And also we do some the pathology tests like the RNA detection and the antibodies detection. And also we need to do flu RNA test and the respiratory related virus detection to exclude all this disease. So if the RNA and the antibody, both of them are negative and the patients just have fever, but and without any the non CT change, and it will be the non-COVID-19 patients. But if the patients, has this detection are positive, or sometimes the patients, the RNA is negative, but the patient has very typical clinical symptoms like the fever and fatigue and sore throat, or the patient has a very typical change of non-CT, we will diagnose the patients with clinically diagnosis case. So we will treat this group of patients the same as clinical confirmed case. Next. Next, yeah. And then for the confirmed COVID-19 patients, so we need to identify who is mild and who is severe. So for the mild patients, actually, we send these patients into the mobile cabin hospital. So if the patients are age younger than 65 years old, and they can take care of him or herself, and the mental is stable and without severe underlying disease, and the patients no fever or just have lower fever, and especially, yeah, if the patient's blood oxygen saturation is higher than the 95% with the rest status, and for some laboratory tests like the neutrophil or lymphocyte ratio is less than 3, or the lymphocyte counts is over 1200 per microliter, and CRP is normal or just mild elevated. Yeah, we will send this group of patients to mobile cabin. But if the patients in mobile cabin, patients has some symptoms like the difficult to breathe or have fever, yeah, we will send the patients to the isolation once again. Next one. Okay, and then so for the patients at the isolation ward, yeah, we have to, as a physician, you have to figure out, who is common type patients and who is potential severe patients and who is severe and critically ill patients. Actually, for these two group of patients, I think we don't need to worry about that, because for the common type patients, somehow, they are not so severe that they will be okay. And for very severe patients, you will pay attention, to patients early, and you will say, the physician will say the patients very often. But I have to mention here is how to identify the potential severe patients. Okay, I think there's a question mentioned in the mail, say, okay, did you see some patients okay, and suddenly, become getting worse? I think actually, if you watch the patients very closely, you will find something, okay? And so for us, even the patients, the blood oxygen saturation is over the 93%. But if the patients have hypertension or cardiovascular disease or diabetes, and the older than 65 years old, And if the patients have fever more than 7 days, and especially, yeah, you have to check the CT image. Sometimes we do the CT image maybe 2 days or 3 days because the lesion just progress very fast. So for some patients, yeah, when they come, okay, the CT looks okay, and 2 days later, and the patients, yeah, just has disappeared. So you have to say, okay, if the multilobular lesion or lesion progression with 48 hours, more than 50%, you have to be very careful for these patients. And also we found that the neutrophil our lymphocyte ratio, if it is over 3.13, and this is the sign for risk patients. And also you have to say the CRP and the D-dimer. Okay, if the D-dimer elevated, yeah, you have to pay attention, you know, on patients also. Next one. Okay, so, and the first part, I briefly introduced the principal treatment of COVID-19 in China. And for the common type COVID-19, yeah, we will give the patients the antiviral treatment and antibiotic treatment if it's really needed. And also we need to treat underlying disease. And for the potential severe patients, yeah, we need to give some respiratory support. It depends on the oxygen level, and also we give some immunomodulatory treatment, and also for supportive treatment and organ protection, like for cardio and for the liver. And also we give some anticoagulation treatment. And of course, for the severe patients, yeah, we will give the respiratory support, and some of them with the CRT. Next one. Next one, Dan Yun. Yes. I think it might be very interesting how to have the antiviral treatment. Actually, right now, there's no any antiviral drugs has been identified to be effective. But in China, we have to use some antiviral treatment. I think some of them actually it works. For us, we use the interferon alpha to be optimize the inhalation, and then combined with one of the medicines. And one is the lopinavir, ritonavir. We use the 2 tablets, BID for less than 10 days. Also, we use the Abidor 0.2 3 times a day for less than 10 days. For some patients, we use the ribavirin. Yeah, ribavirin. So this is the most common medicine we use for antiviral. And for the chloroquine phosphate, and even though it is recommended in our guideline, but somehow for me, I didn't use that, but because I really worry about the side effect for the heart. So there are some, maybe there's some patients use that, but from my personal experience, I'm still very careful for that. Okay, next one. And then for the antibiotic, bacteria and or antifungal treatment, if the patient doesn't have any sign of infection, we don't use bacteria. Because for COVID-19 patients, especially for common type patients, they have the, how to say, their CRP normally just slightly elevated, but the PCT is normal. And there's some problem in the non-CT, but normally they're okay with other organs. So, so we don't use the bacteria medicine. And if it's really needed to be used, and we started to use the levofloxacin or moxifloxacin or cephalosporins treatment. But if the CRP is very high and the PCT is very high, especially for the various severe patients, and you can use advanced antibiotic like the meropenem or vancomycin. And I think another very important part we have to monitor the fungal infection, especially for some patients before they come to our hospital. They already used a lot of antibiotics, and also some patients they already used the glucocorticoids. Also for some patients with the diabetes, because diabetes is a high risk for mortality. And also for the critically ill patients, yeah, we have to monitor when the patients have fungal infection. Okay. And for the immunomodulatory drugs, I think the physicians are very interested in should we use the prednisone, okay, and when, and how much should we use? For my experience, I think for severe patients, we should use that, but you have to find the right time to use that. I think the very key point time is the day 8 to 11, because this is the time the patients may have rapid progress. So you have to monitor the patients very closely, okay? If the patients don't feel good and the oxygen saturation less than 19 or less than 19.3, you have to think about that, use the steroid. And of course, if the patient's RDS or whatnot, you can use that. And another sign is if the pulmonary lesion just progress very fast, and you can think about that. So normally we don't use the large amount. We just use the very small dosage. For me, for my personal experience, I only use the 40 milligram per day for 3 days, and then reduce to 20 milligram another 2 days. But it depends on patient's situation. Yeah, you have to make some decision by yourself. And for the immunoglobulin, for my experience, yeah, I use the 20 gram per day for 5 days. But some patients, but some doctors from the Peking, he suggested to use the higher dosage up to the 30 gram per day for 5 days. So, well, I think still you have to think about patient situation, yeah, to choose, okay, the dosage you choose. Okay, next one. And then I think another very important part is prevention of thrombosis. For us, my personal experience, okay, if the patient's D-dimer level is high, you have to wait until the D-dimer is super high. I think as long as it is high, and also the patient is severe or critical ill status, as long as there's no contradiction, I think you can use that. Yeah, I think this is very important. Okay. And for the other treatment, just like the vitamin C or nutrition or emotional support, I think emotional support is very important, because some of patients, their family member get lost. So they are very depressed. So we have to encourage the patients. And also we need a management of underlying disease and a balance of electrolytes. Okay, next one. And for the respiratory support, this is a very important part. But actually, I'm an infectious disease specialist. Yeah, we can handle the patients if the patients doesn't need to take the vaccination. But as long as they need to take the vaccination, we will ask the help from the Department of Respiratory Disease, and also ask the help from our intensive care units specialists. Okay, for the principle is, if the oxygen saturation is the 93%, yeah, we will give the nasal castor oxygen. I think we need to give the oxygen therapy as early as possible. And if it cannot be maintained up to the 93%, we will switch to the mask oxygen. And then if the index of PaO2 versus FiO2 less than 115, yeah, we have to think about that, use the non-invasive positive pressure ventilation. Of course, for some patients, we use the nasal high flow humidification oxygen, but I think there's some argument with that. And for this part, I think the Professor Chi Hong, yeah, will give more explanation for that. Yeah, she has more experience for that. Okay, next one. Next one. And finally, I will give some suggestion for medical staff. I think all the physician and nurse are really, really brave, but we need to protect ourselves. So our suggestion is minimize the frequency of entering and leaving the isolation wards. Normally, yeah, we have one nurse inside and another nurse outside. Okay, they just talk with each other by phone and what they need. Okay, and second is be pay attention on, even though in hospital clean zones, you need to wear the surgical mask. This is what we do. And also for our medical staff, after they work in the isolation wards, they don't go home, and our government just assign them to stay in a hotel with a single room. And also, yeah, we have every 2 weeks, yeah, we have rotation. So, and then we will have 14 days self-isolation. Right now, I stay at home for isolation. Okay, next one. Well, I think it will be very tough to fight with this virus, because this virus is really tricky and hard to deal. But I think, next one. Next one. Yeah, we will win. I just tell you this the story about these 2 patients, and for this, they are a couple, and the husband's mother passed away, and when he come and his platelet is very, very low, and both of them, you know, discharged. And for this woman, her husband passed away, and when she came, and her lungs, yeah, it's very, very bad, but you know, we just saved her life. So I'm really proud of that. Yeah, we did a lot of work to help the people. Okay, thank you. I think spring will come.
Yes, last slides. Yeah.
Yeah, this last slides. Yeah.
Any words? Any more words, Xin?
No, I'm fine. I'm done.
Okay.
Yeah.
Thank you very much for your excellent summary about the clinical management of COVID-19 in our hospital. So I think that colleagues from the United States may have some questions for you, but I would like to suggest that we will have a question in the free discussion sessions. So we move to the next session is question and answering sections. Firstly, Dan Yun, next slide. So firstly, still Professor Xin will be responsible for answering the following question. 4 questions. Please, Xin.
Okay, actually, I think I already answered the first question about antiviral treatment, because for the chloroquine or hydroxychloroquine, let me see, for chloroquine is on the guideline, but for myself, I think I worry about the side effects. I don't use that, because the other antiviral medicine, I think it works. And also there's some, let me say, research paper show that they didn't show very good, how to say, effects compared to the other antiviral medicine. And for the hydroxychloroquine, it is not in our guideline yet. So if you use that, you have to participate a clinical trial. But I know that it has been used for the lupus, and also I heard that for some patients they just buy this medicine by themselves, and well, it helps the viral clean. So this is for first question. And for the second question, the when initiate the steroids, yeah, I just mentioned that. I think the second week is, especially in the early second week, is the key time. Yeah, if you use that, yeah, if you want to use steroid just during this time, after that, I don't think it will work, because it may inhibit the immune function. So I don't use that after 2 weeks normally. And for the immunomodulators, like the immunoglobulin, I think it may, well, it doesn't have any side effects. I use that, I think it should be okay. But whether it has very strong anti-inflammation, I think it's hard to say. And for the IL-6 inhibitors, yeah, there's some clinical trials, but for me, I don't have shoot up patients for using that medicine, so I don't have any experience for myself. But let me say, the physicians in other words, they use that. They said that somehow, well, the side effects is okay, and the patient's oxygen saturation can be improved, yeah, with the IL-6 inhibitors. Okay, and question 3, we don't use the hydroxychloroquine for prophylaxis, but actually we are doing a research because in the beginning of this year, as many of our colleagues have some symptoms, we really worry about that they will catch the virus, and we used Abidol to take it, and some of them, I think it works. And for Abidol, I don't think it has a lot of side effects. I think it should be okay. It is safe. And the question 4, to check the serum ferritin and IL-6. Yeah, we do that. Yeah, we check the ferritin and IL-6. But my experience is for this virus infection, it doesn't like other virus like the SARS or flu, H7N9 or the sepsis. Okay, the IL-6 jump to very high level, or the serum ferritin jump to very high level. It doesn't. The ferritin maybe around the 600. Normally, most of them less than 1,000. And for the IL-6, and I think maybe for severe patients, maybe around 80 or something like that. So we will check it, but if you just watch the laboratory results, you will say, okay, it seems that this patient is okay, because it's not so bad, you know, compared to our previous experience. Yeah, but you can observe the dynamic change of serum ferritin and IL-6. Yeah, that's all.
Okay, thank you very much. So we move to next colleagues. Professor ZHAO Lei, the Deputy Director of our department. ZHAO Lei, are you there? ZHAO Lei, hello.
Yeah, I'm here.
ZHAO Lei, hello.
Me?
Now turn to you.
Me?
Yes, of course. Hello.
So,
You can see the screen. Please open your equipment. ZHAO Lei.
I think something wrong with her iPhone or equipment, yeah?
Yeah.
Something wrong.
Please, ZHAO Lei. So we move on. Next. Baoju, could you call ZHAO Lei to help him? And now we move to Professor Qi. Professor Qi?
Hello, Professor Yang.
Yeah, okay. Now, just for you to answer some questions. Thank you very much.
Yeah, you're welcome. Professor Yang, Professor Huang Kai, Professor Marcos, and all our colleagues and old colleagues in America. I'm very glad to have the chance to be here to exchange the experience of prevention and treatment of COVID-19 today. And now I will answer some questions. The first one, my answer is, to tell the truth, we seldom use pulmonary recruitment in respiratory failure, which is induced by pneumonia, because some evidence have proved that pulmonary recruitment is more effective in extrapulmonary ARDS, such as shock, pancreatitis, etc. So for patients with COVID-19, they've got pulmonary ARDS. Pulmonary recruitment may not be effective. Of course, if you decide to perform pulmonary recruitment for a COVID-19 patient, you should identify if he has the recruit potential. We can identify this by pulmonary ultrasonography, by blood gas analysis, or by EIT. Be careful of the risk of pneumothorax when performing pulmonary recruitment. We ever carried out pulmonary recruitment in a critical type COVID-19 patient, but it didn't work. Instead, we prefer prone ventilation rather than pulmonary recruitment because it is effective and safe and is a kind of gentle pulmonary recruitment. And it is good to discharge the airway secretions in the gravity-dependent zone. We perform prone ventilation for more than 12 hours every day for nearly every patient whose oxygen index is less than 150. Interestingly, I hear one doctor who is the director of ICU in another hospital in Wuhan. He got COVID-19 and he felt difficult in breathing. He received high-flow nasal cannula oxygen therapy and he knew that prone ventilation was good and he actively turned over himself in bed every day for prone position. And it did work. He has recovered soon. So this is my opinion of pulmonary recruitment. And the second question, if the patient has been tracheointubated and has been receiving mechanical ventilator for 7 to 14 days, yet he hasn't met the standard of withdrawing from the ventilator, we predict he won't withdraw from the ventilator in a long time, and he is not receiving ECMO, we can perform tracheostomy. We often execute cutaneous tracheostomy. The operating room is preferably a negative pressure ward and should be a single room. If this condition is not available, you can open the window and use an air sterilizer. Except for the operators, other medical staff should leave the operating room during the operation. Before the operation, we should ensure that the patient has got normal vital signs and normal coagulation function. We perform ultrasonography to check the cervical blood vessels, the nerves, thyroid cartilage, ring cartilage, and the cartilage ring. We do this to make sure the cervical anatomy, to confirm the operation site, and to reduce complications. We will carry on tertiary protection, that is N95 mask, cap, protective clothing, isolation clothing, double gloves, long shoe covers, goggle goggles and positive pressure head cover, as shown in the photo. As soon as the tracheostomy tube is put into the trachea, we quickly connect the tracheostomy tube and ventilator and use a closed suction tube for sputum suction. After the operation, all surgical instruments were packed and put in double-layer plastic bags marked with COVID-19. All garbage was packed in double-layer plastic bags marked with COVID-19. Someone will collect them and disinfect them. Then the third question.
Next.
The third question is ECMO. In our ICU, we have performed 3 VV ECMO for 3 COVID-19 patients during the outbreak of COVID-19. One is still using ECMO and alive. We are looking forward to a good outcome. According to the 7th edition of the experts' consensus of COVID-19 diagnosis and treatment in China, when the fraction of inspired oxygen is more than 90%, the oxygenation index is less than 80 for 2 to 3 hours, and the blood pressure is more than 35 centimeter H2O, we will carry out ECMO as early as possible. Epidemiological survey found that in China, the COVID-19 patients using ECMO got a success rate of 80%, and that is amazing. And the last question about the predictors for ICU admission, mortality, and effectiveness of measures. If a patient belongs to severe type or critical type of COVID-19, and he needs to receive mechanical ventilation, no matter non-invasive or invasive, or he needs CRRT to maintain water, electrolyte, and acid-base balance, the patient should be sent to ICU for further monitoring and treatment. According to the Chinese epidemiologic survey, among COVID-19 patients, the severe type accounts for 15% and the critical type accounts for 5%. The mortality of COVID-19 in China is 4%. In Wuhan, the mortality of severe type and critical type patients is 40 to 60%. We have some indicators to predict whether this patient will develop into a severe or critically ill patient. 1, the lymphocyte count drops below normal and continues to drop. 2, inflammatory mediators or cytokines such as interleukin 6 or CRP continues to rise. 3, the lactic acid level is greater than 2 and rise progressively. 4, lung lesions develop rapidly. GGO in pulmonary CT is more than 50% of each lungs. If after comprehensive treatment, these indicators cannot improve but worsen, and novel coronavirus nucleic acid continues to be positive, the mortality rate is expected to be high. If the prevention and control measures are done well, medical staff will hardly be infected by novel coronavirus, and the patient's novel coronavirus nucleic acid will turn negative quickly. So these are my answers of the 4 questions. Yeah,
okay, thank you very much for your very clear answering and also very practical recommendation for how to management this severe and also very, very large end stage of the disease. So thank you very much. So now we move to Professor ZHAO Lei. ZHAO Lei, are you there?
It's okay?
It's okay. Can you hear me?
Yeah, I can hear you.
Okay, now move to your parts.
Okay. So the first question is any experience with relapse or reinfection? In my experience, the patient recovered from COVID-19, didn't have a pulmonary fibrosis as commonly seen in SARS patient. So in my experience, with the technique improved, the relapse rate will be lowered because the throat swab for the nucleic acid test is not accurate, and at the later stage, we have tested the sputum, and the test is more accurate. So we think most of the relapse was false negative for the nucleic acid test. And in Shanghai, their discharge criteria include the negative result of the nucleic acid in feces. They didn't find any relapse. So we don't think the relapse is frequently occurred in the patient. And we did not find any cases diagnosed reinfection by now. The question 2 is any increased risk if on ACEi or ARB or NSAIDs. We did not observe more infection in patients taking ACEi or ARB. We think the ACEi or ARB cannot influence the risk of COVID-19. As the fever of patient is low or moderate, and the duration is short, we normally did not use and we don't recommend the NSAID for the patient. I think more concern will be on the breathe. Many patients will proceed to the dyspnea. The question 3 is, are you using hydroxychloroquine and azithromycin combination? And if you are, have you had an ECG QT prolongation issue? And what dosing regimen of hydroxychloroquine? In my experience, the China diagnosis and treatment protocol for the novel coronavirus pneumonia recommend the chloroquine phosphate. The protocol do not recommend the hydroxychloroquine, but I hear from my colleagues and some doctors tried hydroxychloroquine and found a good effect of the patient in the early stage, but the experience is limited because the case is not enough to draw a conclusion. So in my the works in the world, I don't observe the ECG QT prolongation issue because we didn't use the hydroxychloroquine frequently before. The experience from other physicians is the dosage for the hydroxychloroquine is 400 mg daily is safe, and we do not recommend the patient with a history of heart disease and heart symptoms. The question 4, when is an indication for performing electrocardiogram on this patient, and how does it impact care? In my cases, when patient was enrolled into the ward, we will perform the ECG and cardio enzymes for the patient. The LDH is elevated in many patients, but we didn't find the patient with severe heart disease caused the COVID-19. That's all. Thank you.
Okay. Okay. Thank you very much, Professor ZHAO Lei. So we move to Dr. Wang Xiaorong from the Department of Respiratory Disease. Please, Xiaorong. Xiaorong. Hello. Hi. Are you there?
You can move to another one, next one, and yeah, Professor Yang, move to the next one.
Okay. She is not there. Has some problem. Okay. Baoju,
She should.
are you there?
Yes, I'm here, but I think
Okay. Turn to you.
yes, I'm here.
My colleagues from the Department of Infectious Disease.
Yeah.
Welcome.
I'm here. Yeah, Professor Yang, Professor Huang, Professor Marcus, I'm Baoju Wang, and from Department of Infectious Disease. I think this question has already answered by Professor Xin, but I want to add some evidence on this. Dan Yun, please quit the sharing the screen. I want to share something.
Okay. 单云，你退出那个屏幕。
I already did that.
Okay. Okay.
Okay.
Baoju, you can just upload.
Can you see the screen?
No. Okay.
Okay.
I can see.
Okay. But the full screen. You
Yeah.
choose the full screen.
Yes.
Full screen.
全屏，全屏。
Okay, doesn't matter. Go on.
So show the clinical trial done by a French group. Yeah, they just enrolled about 26 people here to take the chloroquine, and the azithromycin if needed. And they from this picture you can see that at day 6 the treated group has a lower positive rate of RNA viral RNA, but this means that it looks like that the chloroquine plus azithromycin is effective. But we don't have any experiments using this for the post-exposure prophylaxis. But in at the beginning, Xin already told that at the beginning of this disease pandemic, some of the medical staff in our hospital use the RB door preventing infections, and we do a very rough study on this. Can you see the picture, the table on the screen? Yes.
No,
No. Next.
no.
You
What
should
we
move.
saw is from the paper is not your slides.
Okay, so maybe it's slower. We compared we compared 40 patients, 40 medical staff who did not take Abidol, and 40 medical staff who taken Abidol, and we find that the RNA positive is much lower in the Abidol treated medical staff, and CD scan positive is also a little bit lower than Abidol treated medical staff group.
Well, G, can you show us the slides? I really want to see the slides. I think that would be very interesting results.
I have already shown, but I don't know what happens. It's
Okay, doesn't matter. Continue.
Okay. So we think that maybe Abidol is much better. We now have enrolled more than 1,000 medical staff, but we have didn't have any analysis. Maybe we should do it soon. Yeah. So the next so what's the
Okay. You should Baoju, you should do very quickly, clearly and very quickly to answer these questions because we have not enough time.
Maybe I already show. I have some addition was because some medical staff in other hospital they use the interferon alpha for nasal spray, and it looks like it works. So maybe you can also use Abidol and interferon alpha for nasal spray. Okay, that's all. Thank you.
Okay, thank you very much to sharing this experience with some drugs for the post-exposure prophylaxis. I think probably this may be used for our US colleagues now. So where is Xiaorong? Xiaorong still cannot hear us? Xiaorong? Hello?
Move to Jia.
Xiaorong? Nanyun? Can you see her?
No.
No?
I can't.
Yeah? She's absent. So we just move to Jia.
I will call her. I will call her.
Pardon?
I will call her.
Yeah,
Okay.
Professor Wang will call her and just move to Jia, please.
Yeah. Yes. Jia?
Yeah. Hello,
Yeah.
everybody. Can you hear me?
Yeah. Yes.
Yes, we can hear you.
Okay.
Go on.
Yeah. My name is Jia, and I got 3 questions. I prepared 3
Nanyun,
slides to address the questions.
please show the slides.
So the first question I got is that how long do patients remain contagious following recovery? Actually, this is a very...
I'm sorry, Jia. We
Yes.
cannot see the slides.
No,
Must
Jia, you need to leave from the sharing screening. Yeah, because here we cannot see the Daniel slides.
No. I prepared PPT, so I have to share my screen.
Oh,
Yes.
okay, that's fine.
Yeah, can you see my
No.
PPT?
No?
No,
It's black.
it's black.
And Nanyun?
Just a moment.
Yes.
Okay.
Then you, okay.
Can you see it now?
Yeah,
No.
we can see it. Yeah, I can see it. Yeah,
Yeah.
I can see
Okay.
the slides.
Okay.
Yeah.
Yeah, the first question is that how long do patients remain contagious following recovery? And this is a very difficult question to answer because so far we only have limited clinical data to address the question related to this question. There are 2 recent papers from Lancet. They show that they try to find out for how long the virus can be detected in patient samples after the onset of the disease. And what they show is that the mean value of viral RNA positive in respiratory samples is 16.7 days after symptom onset. And in fecal samples is 27.9 days. And this can up to 37 days in respiratory samples, and in fecal samples up to 47 days. So this is quite long time. Although I have to emphasize that these are RNAs, so we still don't know if they are infectious viral particles or not. And also you are concerning the contagious status following recovery. There is another study from Germany. What they show is that here you can see these lines, this pink line and purple line actually shows the duration of the symptom in these patients. Normally it's at the first week or 1.5 weeks after the onset of the disease. But here you can see that these are actually viral RNAs in the sputum and also in the stool and also in the swab samples. And you can see that after even 2 weeks, you can still detect viral RNA in the stool or sputum samples after full resolution of symptoms. So this may provide some clues to address this question. And the second question is that any recommendation as to when individuals with mild disease and a positive test can stop quarantine and return to workplace. And yeah, maybe you can find some useful information from my last slide. There shows you how long the viral RNA can be positive in patient samples. And here in China, we follow this procedure. So the decision to discharge the patients is made by first, they have to show no symptoms, and also they have to show improved chest imaging conditions. And second is that they have to have 2 negative, sequential negative results of PCR, and also more than 24 hours apart. And even in this case, when patients is discharged, they have to do another 14 days quarantine. So yeah, you mentioned that now you have difficulty with getting a test kit, but I still highly recommend that do not stop quarantine until another test is performed, because asymptomatic cases can be contagious. And if it's really hard to do the test, you can yeah, use the information I provided in the previous slides to for your reference. And the last one is any best practices on how to reuse N95 masks. And actually here we do not recommend to reuse it. I know that you have shortage with the masks, and due to this reason, actually you use N95 masks when you have close contact with the COVID-19 patients, right? So if you have really close contact with patients, you do not reuse the mask. And also if you perform the aerosol generating procedures, do not reuse the mask. And if the mask is contaminated by any body fluid from patients, do not reuse it. And also if the mask is damaged, do not use it. But except these cases, then if you are going to reuse it, it's better that you cover the mask with another face shield or a surgical mask, and always clean your hands before you touch your mask or adjust your mask. And you can hang your mask in a clean storage area, or keep them in a clean paper bag between uses. And avoid touching the inside of the mask, and no more than 5 times uses per mask. And at last, do not share your mask with others. And this actually, I found this information from the website of CDC. That's all.
Okay, thank you very much. So we move to Xiaorong again.
Okay,
Is Xiaorong
hello.
there?
Can you hear from me? Okay.
Yes, yes. So it's up to you. Please.
Yeah. Okay, I'm so sorry because just now maybe my computer has some mistake, so I can hear from everyone, but can't hear from me.
Okay, doesn't matter.
Okay, I'm so glad to share my experience about COVID-19. And for the first question, is there any way that we can predict clinical deterioration in patients with pulmonary infiltration? Or is there time frame when we can stop observing stable patients? I think we can, whether the patient's conditions has worsened can be judged from the following aspects, such as the deteriorative symptoms. For example, the progressive dyspnea and increased breath frequency and increased oxygen demand. And also we can from the results from the laboratory tests, such as the absolute value of lymphocytes has progressively decreased, and the lactate and LDH increased progressively. The inflammatory factors such as CRP and interleukin have increased progressively. The non-layers in CT scan developed rapidly in a short time, and a large area of consolidation may be present. Other tests such as significant increase in creatine, CT, and other organ injuries such as liver and kidney injuries, the D-dimer increased. Other factors such as the older patients with underlying disease had a higher risk to develop liver conditions. From our previous study about the COVID-19, the median time from illness onset to discharge was about 21 days, which was similar with the 22 days described by Dr. Cao Bing in Jingyintan Hospital. And the average period of viral shedding was about 18.5 in our studies, and 20 days described by other doctors. So I think the average time to observing stable patients may be around 20 days. But for individuals, if the patient's symptom is improved, such as the fever, the temperature is become normal, at least 3 days, and the pulmonary layer showed adverse absorption, and the SARS-CoV-2 RNA test showed negative about 2 times on respiratory samples. But the patients should monitor their own healthy status in isolation for another 14 days, and even in well-ventilated single room if possible. And they also minimize close contact with family members, separate dining, practice hand hygiene, and avoid going out. And for the question 2, on the autopsy study, we have shown that there are detached epithelial and mucus in the bronchi, which was the same as that we have shown under bronchoscope. At the end stage of incubation of very severe patients, we often see more sputum plaques in the bronchus under bronchoscope. But there was almost mild amount of watery mucus in the middle stage of incubation. In the early stage of incubation, there was prominent congestion of bronchus with needle secretion in the airway. And some patients with COVID-19 have hemoptysis, which may be correlated with the hemorrhage and the severe congestion of the lung that have been seen in autopsy. And for the question 3, about the pulmonary vasodilator to improve oxygen in mechanical ventilator patients. The inward pulmonary vasodilators will theoretically dilate the blood vessels and the reduction of blood flow to reduce hypoxia, mediated vasoconstriction, and pulmonary hypertension. However, based on the poor evidence of any mortality benefit of pulmonary vasodilator and more complications associated with inward nitrous oxide, so we did not use pulmonary vasodilator in mechanically ventilated patients with COVID-19 and severe ARDS. Besides, we had used inward nitrous oxide in patients with hypoxic pulmonary hypertension other than COVID-19 several years ago, but the effect was very poor, and it seemed to worsen intrapulmonary bypass. So I didn't have more experience about vasodilators in severe COVID-19 patients with ARDS. So this is my answer.
Okay. Okay, thank you very much for your efforts. Professor Jia, do you have any more words on the second question? Jia? Hello, Jia.
Yes.
Do you want to add some more information? Or no?
Yeah, no, I think I'm fine with this question. Yes, I think I'm fine with the answer of this question.
Yeah?
Yeah, because
Okay.
And Professor Yang.
Yeah.
That share some, my experience, because I several days ago I discussed this problem with my colleague in Tongju Hospital, and some guy told me that he noticed patient with obvious the right ventricular dysfunction, and so it's very, it's like with the pulmonary infection, pulmonary hypertension. So think about the pulmonary infection. So what I think is that maybe that's the cause should be microthrombin, and because the so many pulmonary infection and occurs, and then will increase the pulmonary pressure, and then may cause the the right ventricular dysfunction, and this patient obviously with the the right the good the left ventricular function with the EF value should be above 60%. So I think that it is really a problem, and according to the some patient died just before they died. Looks like some the how to say it's very it's just like man was died just it's not like the other kind of that, because you will that guy died because of the ARDS. Maybe they should keep the they will respiration dysfunction, heart dysfunction like that, but no disease. So I think that may be the problem of the pulmonary infection induced pulmonary hypertension and induced right ventricular dysfunction.
Okay.
So that's what I
okay,
think.
thank you very much. Okay. So Dan Yun, we move to Jun Wu. Dan Yun. Dan Yun. Okay, we move to Wu Jun.
Hello, everyone. I'm Jing. For the first question, my answer is in order to prevent the transmission and timely treatment of patients, we recommend that all confirmed patients be hospitalized. When the number of inpatients exceeds the number of beds, it is necessary to build COVID hospital. Yes, the threshold for inpatient hospitalization led us to decide to build a hospital. Of course, the surge in emergency patients also portends an increase in the number of inpatients. There are two kinds of a COVID hospital. One is mobile cabin hospital to treat mild patients, which is renovated by large public places. And the other is a new hospital equipped with ICU to treat severe and critical ill patients. For the second question, my answer is considering that so far there are no drugs that have a definite antiviral effect verified by clinical trials. And some of existing antiviral drugs have certain side effects. I personally would not recommend antiviral treatment for asymptomatic transmission cases. However, they need to be kept in isolation for 2 weeks, closely observed for clinical manifestations, and regularly reviewed nucleic acid and antibodies. If the nucleic acid and IgM antibody turn negative, it means the recovery. If the nucleic acid and IgM antibody continue to be positive and the clinical manifestations occur, they are diagnosed as confirmed cases and transferred to the designated hospital for treatment. For the third question, we do viral nucleic acid testing for the following 2 types of community members. Firstly, those with fever, cough, fatigue, and other clinical manifestations. Secondly, who has close contact with COVID-19 patients. Thirdly, residents with potential exposure to COVID-19 patients in a clustered outbreak investigations. Lastly, some have a travel history and a residence history in areas where the COVID-19 continue to spread. In the community testing, we found that the transmission within the community is family aggregated, and the presence of a certain number of asymptomatic infections. It is because of these findings that the Chinese government has changed its policy of home isolation, requiring all confirmed cases to be completely isolated. And this policy has cut off transmission between the source of infection and the susceptible person, leading to a sharp drop in confirmed case is at a later stage. That's all. Thank you.
Okay, thank you very much. So we move to the last question. Dr. Fan, now turn to you. Fan.
Yes. Yes, I'm here. I can hear you.
Yeah. Yes.
Hello, everyone. My question is about the family transmission, how to prevent the family transmission. And for these questions, I will introduce some situations of this COVID virus transmissions in China. In fact, many cases of COVID occurs in communities, especially in the family. And there were many cases in which that all members in the families are infected. Father, mother, doctors, grandfather, and mother, all of the members in the families were infected in a whole family. a lot of cases like this. And the transmissions of the COVID virus is very strong. According to the epidemiological studies that shows that the basic regeneration index of the R0 of this virus is about 2 to 4. That means that the patients which a COVID patients can spread this virus to others and cause about 2 to 4 infections. So from this studies, we can say that it is very important to prevent family transmissions of COVID outbreaks. I have summarized several experiences of family members to prevent COVID transmissions in the family. The first thing which concerned is that we should in single rooms with good ventilation. Second, we should ensure that the shared space, just like public areas in your family, for example, the kitchens and bathrooms, is well ventilated. For example, we can keeping the windows open and try to reduce the time to stay in those shared space and put on the surgical mask if you stay in shared space with others. And another point should be considered is that you should cover your nose and mouth with tissues or your empty when you're coughing or sneezing. It is not recommended. It is not suggested to use your hand because respiratory secretions on your hand are more likely to spread once the surface around you in your activity. If you use hand covers the respiratory secretions, the secretions were spread everywhere and leading to the spread of the virus around your environment. And washing your hands with flowing water is very important after contact with respiratory secretion. And before eating, after using the toilet, wash your hands. And hygiene are very important. And if the mask is wet or dirty by secretion, it must be replaced immediately. And hand hygiene carried out after the mask is removed. And another point should be concerned is clean and disinfect frequently contacted surface, such as your nightstand, bedstand, and other bedroom furniture. You can use disinfectant containing 500 milligrams per liter chlorines or 55% every day. Put your clothing disinfection, just like towel, clothing, bright cover, and so on. It is recommended to soak in chlorine for 1 hour or boiling for 15 minutes for disinfection. And the last point should be concerned is that open your windows as far as you can. And in there, the way I suggest that at least twice a day, in the morning and evening, and ventilated for half an hour each time. If the natural ventilation is not available, you can use the export fan to ventilate. Above all, I think the things like I said, we can avoid the family-lasting infections to a large extent? So thank you. This was my answers for this question.
Okay. Okay. Thank you very much for Dr. Fan. Now we move to, because we are already over time of our conference. So Professor Marcus, now turn to you. Marcus, turn to your sides.
I would like to thank you for your sharing your experience with us, which was very helpful, and also for answering our questions. So that I can be respectful of everybody's time. I have a question of actually we still have some additional questions and discussion, but to be respectful of time, should we email those questions to you, or should we ask now? What do you suggest?
Yeah, you're always welcome to send any questions by email. So just collect these questions and send to my email box so I can distribute it to my colleagues. And then we reply you immediately, as soon as possible.
We, again, thank you very much. It is your experience and your what you've done is very helpful to us. We will follow up with questions, and of course, we have a collaboration together. If there's ways that we can work together in this process, we will do it. On our end, we have a combination of our leadership for the institution, cardiology, pulmonary critical care, infectious disease, our infection control people, even our public health people are on the call. So you will hear back from us in that. But to be respectful of everybody's time, I don't have any other final comments. I want to let Gil, if he's still on the line, and I don't know if Professor Liao are on the call, which are our other collaborators in China. Gil, do you have anything else you want to say?
Yes, I want to thank again to everybody for your help and participation. One of the aspects that we are very interested, and I know there is a little of data, is about the experience with pregnant women and the newborns. That is a question that I would like to leave, and somebody has that experience, will be willing to share with us. I will really appreciate. We have always the problem, especially infections during early pregnancy, first or second trimester.
Yeah, these are very interesting questions. Unfortunately, today the colleagues from the same specialties with you does not come. So we can send this question to him, and also I guess they will have some experience to sharing with you later.
Thank you. Thank you.
Okay, you're welcome. Any more questions?
Maybe just briefly, if the cardiology or critical care intensivists, other infectious disease have maybe one question or comment.
I have a question, sir.
Go ahead. Dr. Ramesh, faculty.
So thank you very much for the Chinese colleagues. It was fantastic to share your experience. Question first question is, in moderate disease who are admitted to the non-ICU patients, is there any measures that you have done to prevent them from getting into ICU? Is there anything that you have done? That is the first question. The second question is, what is your experience on non-pulmonary manifestation of COVID-19 in terms of things such as, say, meningitis, meningoencephalitis, pericarditis, myocarditis, or anything like that? Thank you.
Okay, thank you very much. I guess that Professor Qi and also Xin will give some answers. Professor Qi? The first thing is about the ICU.
No, the first question, I think I can answer it.
Yeah, okay. Xin, you Please, Xin.
Yeah. Well, I would like to answer the first question, how to prevent non-ICU patients from getting into ICU, right? This is question?
Correct.
Yeah. Okay. Actually, in my slides, I'm talking about that for this disease, we think it has 3 phases. The first phase is very mild phase, and the second is the rapid progression, and the third phase is recovery. Yeah, for if the patients can survive. So we think the second week, especially in the early time of second week is very important time. So you need to watch the patients very closely. Okay, actually, if the patients are getting worse, yeah, he had some sign. For example, the patients have fever, and when you observe the patients, the oxygen saturation, yeah, even though you give the nasal oxygen and it cannot get improved, and also for respiratory frequency getting higher and higher, and also the patients feel fatigued and don't feel so good and doesn't want to eat. All these are the signs the patients may get worse in a very rapid way. So you have to watch the patients closely. Okay. So, and then you may want to know, okay, even though I know that, what I can do for patients. First, I think you need to check the laboratory test results. Actually, Professor Chi and Professor, Dr. Wang, both of us mentioned that, okay, for CRP high, like the D-dimer is high or the lymphocyte is low, yeah, all these are risk factors. And the second, you need to check the CT for patients, and if the lesions on both sides, yeah, and you have to pay attention on that. And for me, I think this time you can use some steroids, okay, and you can start to anticoagulation. This is very important. And for the other supportive treatment, yeah, you can give to patients, and you can watch for 2 or 3 days, and the patients will get improved. I think for a lot of patients getting into the ICU, because one factor is that so many patients, yeah, and actually the medical staff is shortage, so you cannot observe the patients very closely. I think this is one thing. Second is because we need to gain the experience, so sometimes we're hesitating on should we give the steroid or not, and then you miss the chance. Yeah, this is my experience. Yeah.
Okay, thank you very much. Okay.
So,
Professor Chi, any more?
Yeah, I think that the professor has 2 questions, but I just heard one question.
Okay, you got only one. Okay.
What is the second question?
The second question is non-pulmonary manifestations such as meningoencephalitis or myocarditis or anything else like kidney disease related to COVID. What is your experience?
Professor Yang, could you please translate it into Chinese?
Yes, I think it's related to cardiologists.
Oh, cardiologist. Yeah.
Yeah.
So
Yeah.
what?
Wang Kai.
Yeah.
Wang Kai is not here.
Yeah, I'm here.
You got this question?
Well,
So what's happening? Unfortunately, I didn't understand what
Okay. Okay.
We'll email the question. Yeah, we'll email the question. It's a complicated.
Okay. Thank you. Thank you. You send email to us, and we will reply you afterwards.
Our Dr. O'Neill or Dr. Wang, our cardiologist, you have any questions? No.
No.
All right. How about the pulmonary? Oh, here's Dr. O'Neill as our
I just want to thank all the group for taking the time in the evening. You folks are incredibly swamped, and we greatly appreciate all the wisdom you've shared. We've been furiously taking notes right now, and we'll learn a great deal. And certainly I want to thank Mark for originating this collaboration. It's fantastic, and you'll help many, many of our patients with the knowledge you've imparted to us. Thank you.
Okay, thank you very much.
Anyone from pulmonary critical care want to ask a question? Anybody from public health? So I do have one other another infectious disease question about the, actually two questions. Your experience with immunocompromised pulse infections, transplant, and so on, cancer patients. And then the second is if you used a serum antibody in the treatment.
Okay, okay, Xin. It's just you. The first one is immunocompromised patients, such as tumor patients who have missed chemotherapy and something like that. Is that situations?
Well, I didn't treat any patients with the immunocompromised. Yeah, so I don't have experience for that. Yeah, but let me say, other patients, other physicians, they treat the patients with the like HCC, and but it seems that pretty similar to, to other patients. But somehow, the tumor and the immunocompromised is not the risk factor for the mortality of COVID-19, but diabetes and hypertension. Yeah, this is a risk factors for that. Right. I didn't get your second question. I'm sorry. What's your second question?
Serum antibody, convalescent serum.
Pardon? What kind of antibody?
From convalescent serum from patients that recovered.
So
cannot hear very clear.
It's not continuous.
Use the recover serum antibody from a recover.
Okay, okay. Yeah. 恢复剂血浆 Okay.
Who will answer that? Me?
Yeah, sure.
Yes, no problem.
Okay, Professor Chi will answer question.
Okay, actually, some Chinese colleagues have such kind of experience, especially in Jingyintan Hospital in Wuhan. They have tested or treated more than 10 patients with this recovery plasmas. And also, all of them have a very better outcome after treatment. But it's, there are 2 points should be mentioned. That one is the limitation of the resources of this plasma. Yes, we need the donations from recovery patients, but the number is very limited, and also especially for the very severe patients, we have so many. Until now, we still have more than 2,000 severe patients stay in the hospital. So another point is just about the safety, and also because still patients, persons or the doctors take care about the safety of this treatment, especially for high sensitivities to this transfer of the plasmas to the patients. So it is a very basic questions. So we do not know exactly if we use these strategies in a large amount of the patients, what's the benefits for the patients, and also probably some side effects. So we need more data. This is what I know now.
So, I discussed these questions with my colleagues in different hospitals, and many, physicians has the experience of this kind of therapy. And some of them told me that, so the outcome of the therapy just depends because maybe some patient get the treatment, and recover very fast. But some in some conditions, some patients did not get any good effect from the therapy. So that's I don't know the question maybe just related with maybe the titration of antibody in the serum, or maybe some other reasons. I don't know the cause, but that really depends on. It's not what in every patient. And so what's your opinion of the the therapy of the Qi, Professor Xu Hong?
Yeah, I heard that our president Hu Yu is doing some clinical research on the recovery period serum. In our ICU, we have 2 patients received a recovery period serum, but only once for each patient. And so I think if the patient will show the good result, they will receive more than once the serum. And so I think both the patients don't have any remarkable result. I think we can see what the president has got from the
Okay. Okay, thank you very much.
Yeah.
Yeah. Okay.
Yeah, for my experience, I think the individualized treatment is very important, and actually it's very hard to evaluate. Okay, the recovery plasma therapy is effective or not, because the patients accept so many other medicine, so it's hard. And also, some scientists mentioned that we have to pay attention on ADCC if we use the recovery plasma treatment. Yeah.
So, I'm sorry, I know it's hard to hear me, but because you've had such experience and you've seen so many patients and have used different therapies, I think it'd be very important to share your experience of what you think in what you think is more or less effective since there are multiple treatments that have been used. If there's what I'm getting at is, if there's ways to do studies or trials, on what you're doing, that would be very important.
Yes, you're right. As I know that there are more than 200 clinical trials now is going on in China, and they just can be divided into different aspects, such as antivirus drugs regimens, and our immunomodulatory treatments, and even using stem cells for the treatment of this disease. Of course, some Chinese herbs, and also combination therapy, and so on. So, but until now, there are not very clear results now. We are looking forward for the new data generated from this clinical trial.
Your experience is going to be important for the rest of the world. So we're looking forward to seeing your data.
I wondered, would you mind if I ask one quick question? Hi, this is Paul Kilgore. Thank you very much for your presentations today. This is wonderful. My brief question is your hospital involved in any vaccine clinical trials right now?
Not yet.
Until now, we have not been involved for vaccination programs. But some, as you know, in China now, we have at least 5 vaccination programs against this virus disease is going on now. And at least 2 of them already get confirmed or be approved for the first phase of clinical trial. But until now, our hospital does not have didn't be involved in this program now.
Thank you very much.
Okay. Okay, thank you very much.
But maybe we can close now then. Thank you.
Okay. Okay, Professor Huang Kai, do you have any words?
No, and I think, you know, I just want to say we will do our best to share our experience with you, and anytime, and if you need, so please contact with Professor Dong Liang Yang, or maybe contact with me. Just, you know, anytime we will get a, you know, reply as soon as possible. So, okay, good luck.
Okay, thank you very much, Professor Marcus. Thank you for sending this very helpful, interesting question to us. And also, I hope that we can continue such kind of collaboration for fighting this disease in both sides. So we will do our best to fighting this disease. And I hope that we will have a next meeting or the further collaboration on if you have any needs, just contact me and all my colleagues directly. Thank you very much. And also all the colleagues from Chinese side and also United States side. And hope everyone have a good luck. Bye-bye.
Thank you very much.
Marcus?
Bye.
Okay.
Okay, bye-bye.
Okay, bye-bye.
Bye.